guys, in the last video we discussed about development of TMJ, and in this video we will be discussing the anatomy of TMJ. So let's start. Temporomandibular joint has two components. One is skeletal and the other is a soft tissue component. So the skeletal components are nothing but your cranial components and mandibular components, whereas the soft tissue components are TMJ capsule, ligaments and the articular disc. The cranial component of TM joint is nothing but the area where actually the mandibular condyle articulates. Now this is situated at the base of the cranium. If you have seen the skull, you'll know that it is exactly located at the squamous portion of temporal bone. Okay, so your mandibular fossa is actually present at the base of the cranium with the squamous portion of the temporal bone. Okay, and it's a concave mandibular fossa, and the condyle is situated in it. All right, and that is why it is also known as articular or glenoid fossa. This glenoid fossa is triangular in shape. If you see in the picture, you'll see that this shape actually allows positioning of the condyle, and it is related to the medial pole of the condyle. Got it? Now, anteriorly, if you see in the picture, there is an articular eminence that is seen. Now, this is actually a thick bone, okay, or dense bone which tolerates heavy forces. Posteriorly, there is squamotympanic fissure which extends mediolaterally. Anteriorly, it is known as petrosquamous fissure, and posteriorly, it's petrotympanic fissure. We have spoken about the cranial component. Let's move ahead and speak about the mandibular component. We all know mandible is a U-shaped bone which contains lower teeth. Correct? We all know that it is not directly attached to the skull, but it's attached to a TM joint. Correct? And it forms a lower facial skeleton. The superior aspect of this mandible consists of alveolar process and teeth. The body of mandible is formed by ascending ramus and mandibular angle. Correct? Now, where is this mandibular angle actually situated? If you have seen posterior inferiorly, that is in the backside inferior and downward region, you will see the mandibular angle which is present, and posterior superiorly you will find ascending ramus which is shown in the picture. Got it? Now the vertical plates of the bone extends upwards and forms two processes. One is condyloid process which is present posteriorly, and then it's anteriorly there is coronoid process which is present. Understood? And this condyloid process further attaches to the mandibular or articulates with the mandibular fossa, forming TM joint. Okay? Now in between this coronoid process and condyloid process, there is a mandibular notch which is present. Now that we have spoken about the cranial component and mandibular component, we have completed the skeletal component of TM joint. Now we will be moving with the soft tissue component. So in the soft tissue component, first we will be discussing about the articular disc. If you have seen my last video, you will know that articular disc is basically a soft tissue, okay, which prevents direct articulation of mandibular condyle with mandibular fossa. So it basically prevents friction. Alright, functionally it also serves as a non-ossified bone that permits complex movement of this joint. If you see it anatomically, it is thicker at the peripheral region when compared to the center region, which appears to be very thin. Okay, now it is made up of dense collagenous tissue, is a biconcave oval structure, and because the peripheries are thicker, it has good nerve supply and vascular supply in the periphery when compared to the thinner region. Alright, then let's talk about the attachments of this articular disc. So posteriorly, retrodiscal tissue or posterior attachment. Okay, superiorly it's superior retrodiscal lamina, and inferiorly it's inferior retrodiscal lamina. So the remaining body of retrodiscal tissue is attached posteriorly to large venous plexus, which fills with blood as condyle moves forward. And the disc is also attached by superior lateral pterygoid muscle. Okay, the articular disc is also attached to the capsular ligament, not only anteriorly and posteriorly but also medially and laterally. Because of that, it divides into two joint cavities. So the superior cavity is bound by mandibular fossa and superior surface of the disc, which is shown in the picture. So that forms your superior synovial cavity, whereas the lower or the inferior cavity is bounded by mandibular condyle and inferior surface of the disc, and that forms your inferior synovial cavity. Now we understood how the superior and inferior synovial cavities are formed. Correct? So the internal surface of these cavities are lined by specialized endothelial cells, okay, that form synovial lining. And along with this lining, there is synovial fringe which is located at the anterior border of retrodiscal tissue, which basically produces a synovial fluid which fills both the cavities. That is why TM joint is also known as a synovial joint. Okay, so the synovial fluid appears to be very clear straw colored viscous fluid which is diffused from rich capillary network of the synovial membrane. Okay, now this synovial fluid basically contains nothing but hyaluronic acid and some cells, most likely the macrophages. Okay, and main function of synovial fluid is lubrication of the articulating surfaces. Okay, other than that, it also carries nutrients to the avascular tissue of the joint and clears the debris which have occurred because of normal wear and tear of the articulating surface. Understood that the main function of synovial fluid is lubrication. Correct? So there are two types of lubrications. First is boundary lubrication. So what happens when the joint basically moves? The synovial fluid is forced to move from one area of the cavity to another, and that is nothing but your boundary lubrication. Now, why boundary lubrication is basically important is because it prevents friction in moving joint. Okay, then there is whipping lubrication. Now what happens in whipping lubrication is, it refers to the ability of articular surface to absorb small amount of synovial fluid. Okay, and during function of joint, forces are created between these articular surfaces. So basically whipping lubrication helps eliminate this friction in compressed but not moving joint. Got it? We have already spoken about the articular disc. Now let's talk about the ligaments. Alright, ligaments play important role in protecting the structure. Okay, they do not actively participate in joint movements but act as a passive restraining device that limit and restrict border movements. Alright, so that every time you open your mouth you don't end up popping the condyle out of the cavity. Alright, and these ligaments are made up of collagenous connective tissue so that they do not stretch. So the ligaments are divided into two types, functional and accessory. Alright, the functional ligaments are collateral ligament, capsular ligament and temporomandibular ligament. Accessory ligaments are spinomandibular ligament and stylomandibular ligament. So the first ligament we are going to talk about is collateral or discal ligament. So what happens in this attachment is nothing but the medial and lateral border of the articular disc basically attaches with the medial at the or the lateral border of the mandibular condyle. Understood? So when we say medial discal ligament, basically what happens is the medial edge of the articular disc attaches with the medial pole of the condyle. Alright, and what happens in lateral discal ligament is the lateral edge of the disc attaches to the lateral pole of the condyle. That is why it is known as discal ligament or collateral ligament. Let's talk about the capsular ligament. The word capsule itself suggests that TMJ is surrounded by something, correct? So basically the capsular ligament is the ligament which completely surrounds the temporomandibular joint. Okay, this is a fibrous ligament and is attached superiorly to the temporal bone and inferiorly to the neck of the condyle. And basically, what does this capsular ligament do? It resists medial, lateral, or inferior forces, so that every time you open your jaw, your mandibular condyle just doesn't pop out of the mandibular fossa. Okay, so it prevents separation or dislocation of the articular surfaces. And because it surrounds the TMJ completely, it prevents leakage of synovial fluid also. Let's talk about temporomandibular ligament. The lateral aspect of capsular ligament is reinforced by strong tight fibers, that is lateral ligament or temporomandibular ligament. Now it has two parts. First is outer oblique portion and then inner horizontal portion. Okay, so the outer oblique portion is the one which extends from outer surface of articular tubercle and zygomatic process posterior inferiorly to outer surface of condylar neck. So outer portion basically extends from outer surface of articular tubercle and zygomatic process posterior inferiorly to the outer surface of condylar neck, and it is shown in the picture. The inner horizontal portion basically extends from outer surface of articular tubercle and zygomatic process posteriorly and horizontally to the lateral pole of condyle and posterior part of articular disc. Got it? Basically, the oblique portion of temporomandibular ligament prevents or limits mouth opening, okay, and or prevents excessive mouth opening. So during the initial phase of mouth opening, what happens is the condyle rotates at the fixed point until temporomandibular ligament becomes tight at the point of insertion at the neck of the condyle and is rotated posteriorly. Okay, the inner horizontal portion of temporomandibular ligament limits posterior movement of condyle and disc. So what happens when the force is applied on the mandible? It displaces condyle posteriorly, correct? So this ligament again becomes tight and prevents condyle's further movement into the posterior region of mandibular fossa. It also protects retrodiscal tissue from trauma created by posterior displacement of condyle, okay, and also protects lateral pterygoid muscle from over lengthening or over extension because of posterior displacement of the condyle. Let's move on to the accessory ligament. So first one is spinomandibular ligament. The name itself says that the ligament arises from the spino-sphenoid bone. Okay, it extends downwards to a small bony prominence on the medial surface of ramus of mandible, which is called lingula. Okay, and it helps in limiting the mandibular movement. Got it? Let's talk about the stylomandibular ligament. This is also an accessory ligament. Now the name itself says that this ligament basically arises from styloid process and again extends downwards and forward to the angle and posterior border of the ramus of mandible. Okay, so basically this is a ligament which arises from the styloid process, extends downward and forward to the angle and posterior border of ramus of mandible. Alright, now this is more relaxed when the mandible is open and becomes taut when mandible is protruded. Okay, so basically it limits the excessive protrusion movements of the mandible. Let's move on to the nerve supply of temporomandibular joint. The auriculotemporal nerve mainly supplies temporomandibular joint. Okay, the additional innervations are by deep temporal and mesenteric nerve. Okay, so the nerve supply of TMJ is basically based on Hilton's law. So the principle says that the nerve which is supplying the joint, okay, also supplies the muscles that move the joint and skin covering the articular insertion of those muscles. To the vascularization of temporomandibular joint, posteriorly it's superior temporal artery, anteriorly middle meningeal artery, inferiorly internal maxillary artery. Other than that, deep auricular, anterior tympanic and ascending pharyngeal arteries also supply temporomandibular joint. Like, share and subscribe.